Officer for St. Alphonsus Health System, State Epidemiologist Dr. Christine Hahn, and Public Health Administrator Elke Shaw-Tulloch. With that, I will turn it over to Director Jepson.
Well, thank you, Nikki, and welcome everyone to our press briefing on COVID-19 this afternoon. And a special thanks to Dr. Nemerson from St. Al's. We appreciate him joining us today. Crisis standards of care remain in effect statewide. The number of COVID-19 patients continues to exceed the healthcare resources available. And we see that in our hospitalization data. And Nikki, if you'll share that chart here for just a minute. As a reminder, this shows the average daily census starting in June last year. And this data is all ages, including adults and children. The latest numbers are as of Saturday, October 9th. For this past week, we remained at very high, but slightly declining daily average census numbers. 704 COVID-19 patients on average in the hospital last week, down from the prior week, slightly down. 181 COVID-19 patients on average in the ICU, down from the previous high, and 127 COVID-19 patients on average on ventilators, slightly up from the prior week. All right, thank you, Nikki, for sharing that chart. Our healthcare professionals across the state continue to work very hard. Please take a moment this week to thank a healthcare worker that you know. They deserve it, and they deserve our respect and our thanks. We'd like to show our vaccinated versus not fully vaccinated chart, and I'll give Nikki a second to bring that up. This data is from May 15th, when everyone over 16 became eligible for the vaccine, to Saturday, October 9th. This is the information on cases, hospitalizations, ICU stays, and deaths from case investigations during that time, and shows how many were vaccinated versus those not fully vaccinated. For reference, 52.9% of those 12 and older in Idaho have been fully vaccinated. And as you can see from this chart, this data remains relatively stable from week to week and has for many weeks now. We have 88% of COVID cases, 90% of Idaho COVID hospitalizations, 92% of Idaho COVID ICU stays, and 87% of COVID deaths are from those not fully vaccinated. All right, thank you, Nikki, for sharing that chart. As you can see from these numbers, the vaccine is effective and remains effective, in particular against the Delta variant. For those that are unvaccinated, please consider choosing to get vaccinated. The vaccines work, they're safe and effective. In addition, please wear a mask indoors and in crowded outdoor spaces. And with that, I will hand it over to Dr. Nemerson.
Thank you, Director Jepson, and thank you everyone for being here and helping us to continue to communicate accurate information to the general public. The work that you do is so important to the work that we do. Today, I'd like to share with you a bit of an update on the state of crisis standards of care, particularly as it affects St. Alphonsus Health System. Then I'd like to talk a bit about moving from the concept of pandemic to endemic, and I'll explain more about that. And then finally end talking about how to protect yourselves and how to stay healthy. With regard to crisis standards of care, for the first time in 3 months, we've finally seen a small decline in COVID spread in our communities. This is not universal across Idaho. And while we are seeing this and it creates significant hope that we may finally have reached a peak, there is no guarantee that we've reached that point yet. Sadly, we continue to see a steady increase in ICU admissions and deaths. The vast majority of these, as we all know, are entirely preventable if only patients would become vaccinated. Intermittently, we continue to have patients boarding in our emergency departments in St. Alphonsus Health System, and we run out of ICU staff and beds, both within our system and across Idaho. Our system is a tertiary care health system, meaning that we support every other hospital and health system in the state to try and ensure that patients can get access to the specialty care that only we can provide. And because of the fact that we're continuing to see this massive COVID surge, we can only service those patients that require urgent and emergent care. Similarly, we're continuing to operate within all of our facilities, particularly the 2 hospitals in Idaho located in Nampa and in Boise using non-conventional care delivery models, meaning that our healthcare teams are extended beyond anything that we would normally do. And similarly, we're providing care in both repurposed clinical spaces and non-clinical spaces. We also continue to see record numbers of both COVID and non-COVID patients. Currently, about 40% of our total inpatient volume is related to COVID. But as I mentioned, and particularly understanding that we're only delivering urgent and emergency care, we're still seeing record numbers of patients that are sick without COVID. And in large part, that's due to the fact that now they don't have access to immediate acute care. And so only if they're getting more sick and they move to the front of the line are we able to take care of them. As I said, we've shut down all but medically necessary, we've shut down all but medically necessary time-sensitive procedures. And we're worried because patients are clearly experiencing harm due to the delays that we've had to impose. And indeed, we're sending some patients out of state to receive care, but they too are very full of COVID patients and high patient volume. Our specialty clinics in St. Alphonsus Health System have been reduced, in some cases closed, so that we can dedicate personnel to the care of acutely ill patients, and particularly those with COVID. And then the last thing to recognize is that our colleagues who are protected by the vaccine, while they're experiencing lower rates of COVID than the general public, and the intensity of illness that they have if they do contract COVID from a breakthrough infection, while they are protected by the vaccine, they're experiencing trauma, they're experiencing physical and emotional stress and distress due to the fact that they're witnessing patients who are dying from this terrible disease unnecessarily. And that's what I want to talk to you about now, which is moving from the concept of pandemic, which is the unbridled spread of COVID, which does continue, to endemic, which is a recognition of the reality that COVID is with us to stay. On December 14th of 2020, I told you that that day was the D-Day in the battle against coronavirus. And sadly, today I'm here to tell you that we've lost the war, that COVID is here to stay. And the reason it is here to stay is because we cannot vaccinate enough of the public to fully eradicate the disease. And absent being able to do that and accomplish herd immunity, we now need to move into the phase of recognizing that COVID is going to be a disease to be managed for the long-term future. Part of managing that then is managing the moral injury and the burnout and emotional trauma that our employees are experiencing from watching these unnecessary deaths, as I mentioned, from unvaccinated individuals. They continue to be harassed and even worse, experience other kinds of threats from patients and their families who fail to believe in COVID and worse, believe that we are not committed to their well-being and their recovery, which we are. And so we within St. Alphonsus Health System have now elevated significantly our efforts towards driving resiliency and recovery of our own colleagues so that they can continue to serve the rest of humanity. The last thing that I want to touch on then is how to stay healthy for the general public and frankly for each of you, how to protect yourselves and your loved ones from COVID. And it's a repeat of the same message you've been hearing, which is vaccinate, mask, distance, and hand hygiene. But we recognize that with this Delta virus or Delta variant of COVID, that breakthrough infections will occur. They are extremely unlikely to result in serious illness or death in those who are vaccinated. But who wants to get sick? And we don't want you to get sick because, frankly, we're trying to serve those who are unvaccinated and need us to save their lives. And so what we'd like you to do is, if you choose to socialize with others, be careful who you choose to socialize with. They should have the same beliefs that you do in protecting themselves, and establish social pods with those friends who you can trust. Secondly, socialize outside rather than indoors. We know that being outdoors is healthy and disseminates the COVID virus if somebody happens to have it that doesn't have symptoms. Frequent businesses that are COVID safe. Don't attend concerts and large events, whether they're indoors or outdoors, particularly in those events where the enforcement of vaccination and masking is not present. And then finally, now that we know that the immunity against COVID begins to wane with time, when you qualify for a booster dose of COVID vaccine, get it. And so with that information, and I'm happy to answer questions toward the end of our presentation, I appreciate, again, the time and opportunity to share with you. And I'd like to hand off to my colleague, I believe it's Dr. Hahn or Dr. Summer.
Yeah, thank you so much, Dr. Nemerson. And can you hear me okay, everybody?
We can, Dr. Hahn.
Thank you. Yeah, thank you so much. I just wanted to provide a few brief updates today. One is on our ongoing efforts to increase the use of monoclonal antibodies in the state. Certainly isn't going to get us out of this pandemic, but it is going to hopefully help take some of the pressure off the hospitals and help keep some Idahoans healthier and safer and not in the hospital, even if they do come down with COVID. So I'm pleased to say that Northern Idaho, we continue to see an increase in the use there. The governor's program has that initiative there by Heritage Health has treated an additional over 100 patients since last week. In Eastern Idaho, Mountain View Hospital has also provided over 200 treatment courses since last week. So we're really pleased that those are going very strong. Here in the Treasure Valley, of course, we do have providers, including St. Al's, including St. Luke's, including some other providers that are offering monoclonal antibodies. So it is available, but we are still working on finalizing a state-funded, if you will, an additional monoclonal antibody site. However, as we allocate monoclonal antibody week by week, we have been able to utilize all of the federally allocated product that has been given to Idaho, even though we're actually seeing a little bit of an increase week over week, which we're very happy about. And this week, we actually had, for the first time, the third monoclonal antibody that was recently bought by the federal government is now available to the states, Sotrovimab. And so we will be working with the providers on the state to see who wants to, that has helped augment our total doses. And we're hoping that we can get some providers to start using that. So we're pleased how things are moving forward. Again, my reminder I give every time, these are not vaccines. They provide a passive short-term immunity that do help people not only recover from any current infection, but could provide some short-term protection from infection, but not long-lasting protection like the months or more that a primary series of vaccine will provide, and hopefully longer with boosters and so forth. So we do urge people not to consider these as an alternative. And the other reason is that monoclonal antibody may not be there when you need it. We know that the supply, again, we're reliant on the doses given to us by the federal government. So we urge people to not consider that their number one way to protect themselves. The other thing I wanted to give a quick update on, and most of you are aware, but just that Idaho is going to be very attuned to the progress with the vaccines. And one of them is the advisory committee, the FDA's advisory committee that is meeting this Thursday and Friday. I'll be listening to as much of it as I can between other work, and I'm very eager to hear discussions on two major areas. One is the possible authorization of booster doses for Moderna and Johnson & Johnson vaccines, which of course, those of us that did not get Pfizer are very eager to hear that development. So we may have an authorization for those vaccines as early as this Friday. And then we'll wait CDC to create recommendations for those booster doses. Usually that's been a very fast, just a few days type of process. Secondly, the FDA will be discussing the idea of what's commonly referred to as a mix and match. So if someone received, let's say, one dose of Pfizer and for some reason their second dose was Moderna, can we consider those folks up to date or completely vaccinated, even though that's not a recommended process. Similarly, if someone got a primary series of one vaccine, could a booster dose with the other vaccine also provide protection? So that data will be discussed Thursday and Friday, and that will be very interesting and have a lot of impact on people who maybe not have gone the traditional route or may have gotten a mixed schedule. So please, we'll all be staying tuned for that, and we will incorporate whatever comes out of those meetings into our messaging, our programs, and our planning moving forward. Last point, of course, we're all eager to hear what's going to happen with the 5 to 11-year-old children. We know that Pfizer has put in their application, and that meeting is set for October 26th. So that's just, gosh, that is coming up very soon. Less than 2 weeks from now. So we're really hopeful that we will have an authorized vaccine potentially from Pfizer for 5 to 11-year-olds, which will be a potential game changer for schools, as now most school-age kids will be eligible for vaccination. And we're hoping that will be incredibly helpful to us. We are already starting to plan for the rollout of that. It is a different dosing, a different formulation than what's given to older children and to adults. So there's a lot of planning going on around that. We do have folks in the immunization program going on if there's questions about that. So with that, I think I'm turning it over to Elke Shaw-Tulloch, our administrator.
Great. Thank you, Dr. Hahn and Director and Dr. Nemerson for your comments. I appreciate them. For weeks and weeks now, you've heard from us and others continue to express our grave concerns about our healthcare capacity as people continue to become infected in the state. And the toll it has taken for almost 2 years now is tremendous. We're in crisis centers of care. We continue to see a mounting death toll. In addition, our schools are facing stress, as evidenced by schools opening and closing and reopening in order to address COVID cases in school settings. And while you just heard that we may be seeing a stabilization in cases, we are still cautious about because Halloween and many other holidays are right around the corner. And it's important for us to emphasize that we need to remain vigilant and diligent with our mitigation measures to ensure that people are not becoming in contact or continuing to flood, our hospitals, and so we can keep our schools open. Idaho continues to have high community transmission of the virus. You can find a lot of information on our coronavirus.idaho.gov data dashboard, as well as what you can see on the CDC website. Holidays and events where people gather are ripe for the spread of COVID, as we know, particularly for those who are unvaccinated and especially for our young children. We continue to see the incidence rate among children ages 0 to 4 increase. It's important we protect them and others during these events. To reiterate a few points that were made by Dr. Nemerson, some tips for safe holiday gatherings include getting the COVID vaccine if you're eligible, wearing face coverings if you're in crowded environments, staying 6 feet apart from one another, move your events outdoors if possible, and if you can't be outdoors, increase the fresh air ventilation in indoor settings. And of course, always consider virtual events. If you're not feeling well, please get tested and please stay home. Halloween's in just a few weeks, and trick-or-treating is fun, especially if everyone can stay safe. We encourage trick-or-treaters aged 2 and older to wear a mask that covers their nose and mouth to reduce the risk of encountering someone who is ill. Find some fun and creative ways to incorporate those proper fitting masks into their costumes, and we're really encouraging parents and guardians to role model this behavior and wear a mask as well. If you are beyond the trick-or-treating phase, please follow our mitigation and risk reduction measures. Get vaccinated, wear a mask in crowded environments, stay home if you're sick, and get tested. These are the same messages we keep saying. We know that they work, which is why we keep reiterating them. And with that, Nikki, I'll turn it back to you for our question and answer period.
All right, thanks, Elke. So we will now take questions from our media participants on the call here today. Please raise your hand in WebEx or type your questions into the chat area. And then when I say your name, please unmute yourself and announce your name and media outlet before asking your question. And then remember to clear your hand when you're done, so everybody gets a chance to ask a question. Today, our first question is going to come from Melissa Davlin.
Thanks, Nikki. Melissa Davlin with Idaho Public Television. I have so many questions based on what you said, Dr. Nemerson, that we're entering an endemic phase of this. Looking forward, I realize you don't know what that might look like with different strains, but how is St. Alphonsus and the Idaho Department of Health and Welfare preparing for this reality in our future? And does that mean potentially going into crisis standards of care multiple times a year if we have multiple strains that have big spikes? What does that reality look like?
So Melissa, I'll answer first, and then I'll let the department answer for itself. First of all, I want to give confidence to the state, to the public, to know that we have incredible coordination now across the state, championed by IDHW, the Office of Emergency Management, all of the health systems and providers that are involved. So we're fully prepared to develop whatever, to accommodate whatever comes forward. As you say, it is entirely unpredictable at the present time because what we don't know is what strains will emerge as people continue to be unvaccinated and the disease continues to spread. What we do know, though, is that we expect to see surges periodically, and as they occur, hopefully they won't be as severe because at least 50% of the public will be fully vaccinated. The question, of course, is, how contagious and how deadly will the next variant that emerges become? And the only thing I can tell you is that medical history suggests that, like with the flu, the more severe surges like we're experiencing right now are much, much less common. But nevertheless, there are episodes, at least on an annual basis, that we'll have to deal with. And then finally, I think you were asking about how St. Alphonsus itself is prepared. I can tell you that we have no intention of standing down our incident command structure, which is the principal structure for responding at a moment's notice to any public health crisis. And we're in full gear, if you will, to continue to deal with this. My biggest concern, though, as I mentioned, is the stamina of our employees and those who are going to continue to care for their fellow man as we go forward, because none of us are superhuman and we all have a limit to how much work we're able to do and how much stress and despondency we're able to handle. And that's compounded by the fact that too many people are coming into our hospitals questioning what we do. One of my leaders said to me that her greatest relief just a week ago was when a patient said to her, "You're the doctor, do what you think is best." And she broke into tears because it had been so long that she had heard somebody express that kind of confidence, meaning that too many people are not expressing that confidence, and we need to hear them more.
Yeah, thank you, Dr. Nemerson, for addressing that. And from the department's standpoint, certainly I'm going to echo what Dr. Nemerson said about continuing to make sure that we're prepared. We're supporting hospitals. I feel we've built a really good relationship, and to include in the list of relationships that Dr. Nemerson mentioned is also the Idaho Hospital Association. Really working together as a great collaborative team, so we have that good foundation from what we're experiencing now. But I would like to ask Dr. Hahn if she would maybe elaborate a little bit more on the change from pandemic to endemic and what that means from a state epidemiologist perspective.
Yeah, hey, thank you, Elke. Yeah, I think that, a lot of analogies are made often to influenza, and I think that's the best way to consider as we, as Dr. Nemerson alluded to, I think a lot of experts now feel that we are probably, this virus is not going to go away. Remember, viruses surprise. One thing we've learned is we do not understand this virus fully, and it will continue to surprise us. But it doesn't appear likely that it's going to go away. It is very likely going to continue to circulate, and we can only hope that over time it becomes a milder and more tolerable virus, if you will, kind of like some of the other seasonal coronaviruses are now. That said, especially if it turns into a winter respiratory virus, it's going to add on to our annual flu outbreaks and other respiratory outbreaks, and we may find ourselves facing more shortages or critical times. And of course, as a department, we will follow the hospitals as far as what they need and support them to try to keep them, functioning and of course, working by educating the public to prevent outbreaks as best we can. But yeah, the transition, if you will, I always think about the fact that 1918 pandemic, the very, very severe pandemic, influenza pandemic, that virus is, the descendants of that virus is still with us. It is one of the influenza strains that circulates to this day. So that virus never went away. And it is very possible that we'll end up in the same position with the coronavirus, as Dr. Nemerson alluded to.
All right, we'll move on to our next question. We've got several lined up here, and that's going to come from Audrey Dutton.
Nikki, I think that's who just asked the last question.
I'm sorry?
Can you all hear me?
There we go.
Okay, thank you.
There we go.
Juggling a few things here. I'm wondering, there was a new preprint paper that came out that talked about loss of primary caregivers, and it estimated that nearly 500 children in Idaho have lost a parent or other primary caregiver. I'm wondering if you can talk about that at all, what you're hearing and seeing. And this was only through June, so it was before the Delta variant, brought on as many deaths as we've seen, and some younger people's deaths as well. I don't know who to direct this to, so maybe Elkie.
Yeah, thanks, Audrey. That's one of my jobs on this call, is to make sure I field it to the right place. I am not deeply familiar with the paper that you're talking about. I saw sort of a high level version of something related to that, but I'm going to see if Dr. Turner might want to address that question.
So Audrey, is your question really about numbers, or what the department's plans are to address the fact that we've got children who've lost parents? I just want to make clear what you're asking. And if you're talking, we can't hear you, Audrey, so sorry.
How about now?
Yes.
Okay. Could you address both of those?
Yeah. So I think what I'll do is I'll address the numbers part of it, and then I'll probably kick it back to Elkie or the director to talk about the impact on children's well-being as a result of the loss of caregivers, parents, or the people that are caring for them, like grandparents. What we are seeing, and I don't think this should be any surprise, is we're seeing a younger population of people who are dying from COVID during this surge than we saw during the last surge. And when I say that, what I'm talking about is this time, if we look at deaths for this time of the year during the last year, 2020, we were seeing over half of the deaths were in people over, 79, 80, and older. What we're seeing during this current phase of the pandemic is we're seeing much, much younger people dying. In fact, the majority of people who are dying are younger than 70 years of age. And we're seeing almost a tripling in the percentage of deaths among people who are less than 40. So it should be no surprise to anybody that this is impacting parents of young children who may fall victim to COVID. So we are seeing a younger population dying, and it is going to have an impact on Idaho's children. And I'll kick it back to Elkie or the director to sort of talk about children's well-being.
Yeah, thanks, Kathy. And Director, do you want to add on to that?
Yes, thank you. Thank you, Audrey. It's a really important question, and it's a tragedy in those children's lives to lose a parent, prematurely lose a parent. And I think we can all understand or have empathy with how impactful that is to a family, and particularly to a child that's to lose a parent. It's something that we worry about a great deal. I think it's going to underscore the importance of support systems in those children's lives. And those support systems will need to be strong, and that it starts with immediate family members, both immediately as well as extended family members to support and surround those kids. Certainly in the school environment, that becomes critical to provide support for these children as they spend their days at schools and helping them there. And then we really will need to be focused on how we continue to increase the behavioral health system in Idaho, particularly for children. Just recently, the Idaho Behavioral Health Council completed their strategic action plan. Director Sarah Omenson from the courts and I are the co-chairs of that council. And a large portion of that plan is focused on children. There's also a large portion on adults. But it really feels really important right now for many reasons, including this one we're talking about, that we shore up the behavioral health system that supports our kids. And that plan is available on our website. It has lots of things we need to do to shore up that system for children.
All right. Thank you, Director Jepson. Our next question is going to come from Ian Stevenson.
Thanks. This is Ian from the Idaho Statesman. This is probably for Dr. Turner. A couple weeks ago, the modeling used by Health and Welfare for future hospitalizations showed a peak of 1,900, potentially 1,900 new COVID-19 hospitalizations over a period of a single week, sometime in late November, with peaks of around 2,100 cases in a week and 305 deaths around that time too. I wondered if there's been an update to that modeling since then, and whether that's still the case or whether there's new data or new projections there.
Go ahead, Dr. Turner.
Thanks, Elke. Thanks, Ian. The modeling is being updated. We're still tracking pretty high, the high end of the curve. However, as many of you might be aware, some of our local public health districts have been experiencing some difficulty keeping up with the number of lab reports coming in, and so case investigations are not being completed as quickly as we would hope they would be. And so we're roughly almost 9,000 lab reports in the red, so to speak. So our case counts are not really reflecting what they should be when we project them onto that curve line. So one of the things that we are doing is offering assistance to our local public health districts to see if we can help them get caught up, so we can have a better idea of where we might be. Some of those reports have to be adjudicated in order to, determine residency, whether or not they're even an Idaho resident, duplicates, that sort of thing. So it's important that those be adjudicated, and the state is offering assistance to try to get them all up to speed. So the long answer to your short question is that I'm hesitant to overlay our case counts on top of that projection at this point until we are more caught up on what our case counts actually are.
Okay, thanks, Dr. Turner. Our next question is going to come from Andy Sullivan.
Hi, folks. Thank you for taking the time to do this. Ms. Shaw-Tulloch, could you give us an update on the funding for school testing, please? And Mr. Nemerson, wondering if you feel like you have been getting the financial resources you need from the state to fight this surge.
Great. Yeah, thank you for the question, Andy. For an update for the school testing monies that we have out there, remember we made available $30 million for schools, and 53 schools or school districts have, pull this in front of me so I can look to the straight front. 53 schools or school districts have indicated interest in that funding. Right now we have funding in progress for 19 organizations. We do a sub-grant process to the tune of about $4.3 million that's been requested. Funding has been declined by 13 of the organizations that only want access to testing kits. So we are working with contractors using that same pot of money to be able to purchase test kits for schools. So we have a contract specific for schools to provide vault test kits. And we have $10 million that has been allocated towards providing those test kits. So we've ordered over 25,000 kits this last week. And then also because the schools are really looking for more timely results than the vault test kits can provide, because those are a longer PCR test. Our Idaho Bureau of Laboratories, and Dr. Ball is on as well, can expand upon this further. But they are looking at some contracts with vendors that can provide more rapid test kits. For example, some Kydell Sophia test kits, Q, which is a PCR-based shorter term test, and some other options. So that's the update on the school-based testing. And then the rest of your question was for Dr. Nemerson, if you'd like to address that about funding made available to hospitals.
Yeah, and if we could, before we do that quickly, could you explain why it is important for schools to do these tests? What's the role here? Are you heartened by these numbers? This doesn't look like there's many more school districts than we had a few weeks ago, right?
Great comment, and I will have Dr. Turner kind of round this out as well. But certainly, we want to make. I don't want this to indicate that schools aren't interested. Many schools already had things in play, schools and school districts, and didn't need to take advantage of the money that's available. So they already had, they were already working with some local vendors, for example, to provide testing. Certainly testing is incredibly important, and we keep emphasizing the need for testing to make sure we're identifying cases quickly, so they can swiftly be addressed to make sure that there's not further spread in the school setting. So Dr. Turner, if you have anything else that you want to add.
Thanks, Elke. The only thing I would add is to just reiterate that there are schools that are already had programs in place using other sources of funds, and we also have some schools who would like to implement a testing program and may need to seek permission from their boards before they can take the funding for the planned implementation. So there's multiple reasons why schools may not have jumped in all the way up to their neck so far, and we're just going to be here for those schools that do want to take advantage of the funding.
Okay, thank you. And for Dr. Nemerson, do you feel like you're getting the funding and the financial support you need from the state and other sources for dealing with this?
Yes, Andy, we are.
Okay.
And I got to say, I'm really grateful for the support the state's provided and also the Federal Emergency Management Agency, FEMA. If it weren't for the personnel that we've been able to hire through the additional subsidies, because as everyone knows, there's demand across the entire United States. And so traveler caregivers can go anywhere they want to get jobs, and the salaries and the subsidies that are being paid are just out of control. Without those subsidies, we wouldn't be able to serve the patients that we're serving right now. So we're incredibly grateful, and it is sufficient at the present time.
Great, thank you, everybody.
All right, before we move on to the next question, I want to point out that Director Jepson has included a link to the Idaho Behavioral Health Council in the chat. You can find the strategic action plan there that will outline some of the additional help for children's mental well-being. Our next question is going to come from Rachel Cohen.
Hi, this is Rachel from Boise State Public Radio. I think this question is for Director Jepson. I was wondering if the department is aware of how many healthcare organizations are in crisis standards of care or have reached that point at some point in the past month or so since mid-September.
Yeah, thanks, Rachel. And Director, do you want to respond?
Sure, thank you, Rachel. Excellent question. This is our first time going through crisis standards of care, and a lot of access hospital with it's 8 to 10 beds, you could spend most of the day doing just fine, and then you have that one critical patient that comes in that you are having trouble getting transferred to a tertiary care that's beyond the level of service that you are equipped to handle, and that actually puts you into a crisis standards of care situation. Hopefully that patient gets transferred, and hopefully within a couple hours, and then that takes you back out. And so what we've found is that for most of the, particularly the critical access hospitals, it's a very fluid. And so we do not try to attempt kind of who's moving in and out of crisis standards of care to track that. What we do instead is we have, and Dr. Nemerson mentioned this in his comments, we have a very robust daily process where we check in with literally every hospital in the state to see how things are going and to coordinate resources. And we find that to be way more effective and way more important than trying to figure out who's officially in crisis standards of care. Way more important that we're finding out who has resource needs and how we solve those. And that's where we really spend our time with the hospitals across the state.
Okay, thank you, Director Jepson. Our next question is going to come from Elizabeth Hadley.
Yes, thank you. Thank you for doing this, and thank you for taking my question. I'm not sure who can answer this, but I am just wondering, you know, are you noticing or feeling as though healthcare workers, where they once had, were proud of their work and, you know, felt some accomplishment, are you noticing that maybe they're not feeling that anymore, or they don't want to, you know, advertise that they're working in healthcare? Like, I feel as though there's this divide between people these days in everything, in every part of our lives, and it shouldn't be that way. But, you know, especially in this, where people are taking care of other people, and now maybe this is something that they don't want to, you know, they're not feeling as they used to.
Yeah, thanks, Elizabeth. I would say yes as the immediate answer to your question. You heard Dr. Nemerson mention it in the beginning. We're hearing that across the state from healthcare workers, just feeling a lot of fatigue, compassion fatigue, physical fatigue. And I want to make sure that we turn it back over to Dr. Nemerson, because I think he really had some great points that he made in the very beginning that would be great to reiterate about how his staff are feeling right now, and healthcare workers in St. Al's and others.
Yeah, I would say, first of all, that healthcare workers, when they're on the job and they're working with their colleagues, feel immense pride in the work that they're doing. And that's manifest by the fact that they're taking voluntary extra shifts, working hours they've never worked before, and they're working under conditions they've never experienced before, stretching the teams in ways that are very innovative, but not what we would like to be doing, and caring for numbers of patients beyond any healthcare team to patient ratios that we've ever experienced before. And so there's tremendous pride in doing that, and people should feel that way. And we encourage that. And indeed, within St. Alphonsus Health System, this afternoon, in fact, we're going to have a WebEx amongst colleagues just to communicate their experiences and demonstrate the good things they've been doing for themselves and for their patients, and also talk about the challenges and the distress that they're experiencing. But to your other point about when they're outside of our four walls, do they feel like they need to hide their occupation? Do they need to be concerned about their safety? In certain circumstances, absolutely. And I've heard story after story of colleagues being harassed by people in the parking lot. I've heard other stories about going to social events where they are challenged by people who don't necessarily share the same set of beliefs that they do, and how difficult that is, and that some of our colleagues have chosen to simply not talk about what they do for a living as a result, particularly if they can predict that they're going to be in an environment where they're going to be challenged on that basis. It's a tragedy.
Thanks, Dr. Nemerson. Our next question is going to come from Hayat Noormina.
Hi, thank you. This might be a question for Dr. Hahn. Would someone be able to speak to the difference between COVID and some of the other viruses that have stuck with us over the years? Can we get a sense of how vaccination rates in COVID compared to vaccination rates of other viruses that we have as we transition into it being an endemic over a pandemic? and what kinds of challenges that might present?
That's a great Dr. Hahn question.
Thank you. Yeah, that's a great thought question. A couple of things to consider. We have used vaccines to successfully eliminate, some diseases, smallpox, of course, always being the flagship of that, that truly has been eliminated. But most vaccines continue to be needed, and that's why kids today don't get vaccinated against smallpox. But most viruses and other diseases that we control with vaccines are not eliminated through vaccines. That's not usually what they do for a couple of reasons. One is that sometimes they don't eliminate transmission and carriage, and we've found that certainly with this COVID vaccines out right now that people can still acquire the infection even if they're fully vaccinated and can transmit. So that doesn't bode well for eliminating. The other problem, of course, is, as Dr. Nemerson alluded to earlier, we don't have everyone vaccinated that is eligible to be vaccinated, so we have a continued ability for the virus to circulate in the population. When we look at other, I'm going to go back to influenza a little bit, partly because it's influenza season, and every year we urge Idahoans to get vaccinated. And Idaho is one of the lowest in the country as far as our influenza vaccination rates overall. You can go on CDC's FluView website and you can see the different state immunization rates in the general population. And we're usually down there in the 30-something percent. And it varies year to year, of course, and it varies depending on what age group you look at, with our seniors being more likely to be vaccinated. But if flu is any sort of like something for us to look for guidance, we continue to struggle to get people to get their influenza vaccine. So it's a long, complicated topic, but I would just say that the history of diseases in this country and the history of vaccination in the country doesn't seem to be pointing us towards this disease, and this vaccine is going to be something that we can eliminate like we did smallpox and like we almost have with polio, a vaccine, for example. So there are other diseases much more likely that we could potentially eliminate than I think this coronavirus.
Thanks, Dr. Hahn. Our next question is going to come from Ariel Dreyer.
Great, thanks. This is Ariel with the Spokesman Review. Can you hear me?
Yes.
Yes, we can hear
Perfect.
you.
I've been covering what's happening in North Idaho as well, and I'm curious if hospitals are asking the department to extend the financial support for staffing into this winter, and if that will be possible. And then at what point do we think hospitals would be able to get out of crisis standards of care? Thank you.
Thanks. I'll take the first part of that, and then I will send the second half over to the director. But the first part of that is we have extended the funding available to hospitals through the end of December. And we will continue to evaluate the need for extensions of the funding. We are also working with our partners, the Idaho Office of Emergency Management, and our federal contract that we have to provide staffing support, to evaluate as a request for assistance come in, and to make sure that if those requests have already been placed, for staff that's already been placed in healthcare settings, if that needs to be extended out longer than the original time frame, we're making some of those requests. So for example, in North Idaho, we had our GSA contractor come in and help provide some staffing support. Department of Defense also provided staffing support. And the window of time for the initial deployment, excuse me, as it's coming to an end, we know that they're still operating in crisis standards of care. They still need that staffing support. So we continue to evaluate on a regular basis how long we need to extend that. And, but many states are experiencing the same thing. So we do have some restrictions that may start applying in the near future. I don't know exactly what those are yet, but we have to be cautious about the fact that the federal rules may not allow us to extend them into perpetuity, but we're making every effort to extend those as long as we can. But certainly we have funding that's extended into the end of December. And Director, I don't know if you have would like to follow up on the crisis standards of care piece.
Yeah, so I'll, just a few comments on that, and I think that was Ariel who asked that question, so thank you. We all of us would like to get out of crisis standards of care as quickly as possible. None of us really wanted to be here in the first place. However, what will drive that is really the situation that we have, and as we've mentioned before, the driver of why we're in crisis standards of care is we have too many COVID patients that have overwhelmed our healthcare resources. And so what will take us out of crisis standards of care is when those things come back into balance. And as you heard Dr. Nemerson talk at the beginning, that we still have a large number of patients coming in, even with extra resources, and many extra resources still exceeding those resources. And so that really will be driven by the number of cases coming back down, which we hope is soon. We don't know if that's soon, but we hope is soon. Until we can get back to our normal standard of care across our hospital facilities. For a slightly more technical answer to that, we have on our website the crisis standard of care documents. It's on coronavirus.idaho.gov under resources. And in there essentially is a checklist of things that we've asked hospitals to use as we go into crisis standards of care. And what we'll look for to come out is that those things become unchecked, if you will. So if we have patients that are being treated in non-traditional areas, for example, something we'll look for is that goes back to something that's more normal. Or if we have nursing ratios that are stretched beyond the normal standard of care, we'd be looking for those to come back into normal. And I would just check to see if Dr. Nemerson has anything he wants to add about the kind of how we know when we come out of crisis standards of care.
Yes, Director. I think you've captured it entirely, but the way I like to put it within my own health system is it comes down to the very next patient. Can we take care of that patient the way that we used to? And when we are able to do that, then we'll be out of crisis standards of care, or at least back into contingency standards. And we're not there yet, and we're not even close.
Okay, thank you, everyone. We're going to move on to our next question, and that's going to come from Kyle Fonensteel.
Thanks, Nikki. This is Kyle from the Postregister in Idaho Falls. So I'm curious for when health officials will be able to say that we are on a downward slope from this surge. I know that case figures are out of whack right now because of the backlogs and test result processing. But hospitalizations have been on the decline for a couple of weeks now. And last week you said, both Director Jepson and Dr. Turner said that you weren't sure if this was the end of a peak. I'm wondering at what point will you be able to tell if we've exited a peak, and how and why will you be able to tell that?
Thanks, Kyle. I would like to use my phrase, we're cautiously optimistic that that's what we're seeing, but we also know that we still have that backlog of lab reports that need to get caught up. And Dr. Turner was talking about it earlier, so I will have her follow up.
Thanks, Elke. Thanks for the question, Kyle. So I think one of the indicators that is the best week to week and determine a trend, but I think 4 weeks of declines would indicate to us that we may be on the downside.
Kind of this slow incremental uptake, and a clear gulf between the vaccination rates for the kids
contracting COVID. I think also being realistic of what we're seeing or what we've seen across any survey data of parents in Idaho and their intentions about vaccinating. So short of that, I think we would just when the FDA and the CDC review that data and make sure and say that the benefit outweighs the risks, that it is a safe and effective vaccine, if that's what the data is telling us. And just ensuring parents that that's what is being by their physician, and secondly by their family and the people and friends that surround them. And so it's going to be incredibly important that we deliver positive messaging and consistent messaging through our physicians and the places where children receive care. And so in St. Alphonsus Health System, we're already preparing for a communication campaign. I don't want to call it a marketing campaign because we're not selling soap here. We're selling well-being, and we want to sell the truth, and people have to be able to trust us, which I talked at length about the cynicism that's out there. And so we want to be in a position to deliver clear, strong messages that the vaccine is safe, it is effective, it will protect your child against the rare complications of COVID in children, including multi-organ dysfunction syndrome, which can be deadly. Very, very rare, but who wants their child to be the one in 10,000 that dies? And so we want to be very clear about that. And we also want to be clear about the fact that if you protect your child, you're protecting yourself and you're protecting grandpa and grandma and the other people that surround that child.
Nikki, you're muted.
There we go. Mute button. Mute issues. Oh, good grief. I have a couple of questions from Audrey Dutton in the chat. They're both data related, so I'm going to go ahead and ask them back to back. Dr. Turner would probably be the best person for these, and then Dr. Nemerson might want to jump in on the first one. Her first question is, if there's hospitalizations have decreased, but admissions remain high, what are the most likely reasons for this?
Dr. Turner?
Thanks. Audrey, that's a good question. So as you know, the hospitalization census data this is how many people are in our hospital on a given day at a particular point in time. And then admissions are really what happened the day before. And it is very possible that you could have admissions sort of plateauing or even, maybe going up a little bit and your total census declining as patients are discharged because they're recovering or they die who are hospitalized. So it is possible to have both of those things at the same time for a given moment in time. That's a data perspective. I'm going to turn it over and to Elke to kind of facilitate the rest of that question.
Well, Kathy, you're totally okay to go ahead and ask Dr. Nemerson to.
Oh, Dr. Nemerson, go ahead.
I'll try to give you a different perspective, which is the actual clinical operations within a hospital. There's really three groups of patients now that we're seeing in our hospitals. The first are the non-COVID patients. And believe it or not, they tend to have the shortest stay these days because we're doing emergency and urgent care. We're attending to their needs quickly, and then hopefully we're getting them out of the hospital quickly. And so that's the first group of patients. They can have either an incredibly long stay because they've had massive complications that brought them into the hospital, or they have acute care needs that are rapidly addressed and they're out. And so I would suggest that that's in that group, the predominant number. Then there's the patients that have COVID, and there's two groups of those. The first are the ones who are going to end up in our intensive care units, and some of whom are going to die. The duration of that illness from the time that they become symptomatic to the time that they either recover from critical care or they pass away is generally at least 3 weeks, sometimes measured in months. And so they have an incredibly long length of stay. And then you have the other patients who recover from their COVID without needing critical care, and they have a shorter length of stay, usually measured in a handful of days. So when you add those three groups together, that determines the overall average length of stay in our hospitals. And what we've seen throughout the state and in my own system is we have these sort of, I'll call them mini waves of patients where a group of them will be in the intensive care unit, will have an extremely long length of stay. Some will pass away, some will recover and be discharged. And then we get a small amount of relief, if you will. And then patients come from the general medical surgical units and fill those bed spaces. And then, as I said, the other group of COVID patients that are having the shorter length of stay. So when you're comparing the overall net effect, it's ebb and flow, if you will, that we're seeing on any given day and really any given week.
Thank you, Dr. Nemerson. Audrey's second question is, are hospitals reporting the number of patients who had COVID-19 at any point in their hospitalization, or do their daily numbers only include patients who are actively on isolation that day?
Dr. Turner?
So, of course, it's complicated. So, Audrey, it depends on which data point you're talking about. I will tell you that if you are referring to the data that's on our COVID-19 dashboard, which is the number of patients with suspected or confirmed COVID, that is anybody who is actively in isolation as if they had COVID. It might be that they're waiting for the laboratory test, or people who have confirmed that they do have COVID-19. Our ICU is people in the ICU with confirmed COVID. So they have a positive lab test for confirmed COVID, and that's the same as our pediatric data. Now, if you're talking about a different variable that is in the HHS Protect data, I'm happy to talk with you. Maybe we can talk offline, and I can go through the data dictionary with you on how they're supposed to be answering those questions.
Thanks, Dr. Turner. I have been given the green light to go a few minutes longer from Director Jepson. So I see we have two final questions, one from Melissa Davlin and one from Ian Stevenson. So we'll go ahead and start with Melissa Davlin.
Thanks, Nikki. I was wondering if anybody is keeping track of the threats made against healthcare workers or times that law enforcement has had to be called in the state as opposed to just a jurisdiction by jurisdiction or hospital by hospital level. And I was also wondering if anyone has been in touch with any of the nursing schools to find out if this is affecting recruitment for future healthcare workers.
Yeah, those are great questions, Melissa. We do not, as Health and Welfare, are not tracking threats that we know of. We hear things anecdotally, of course, about threats to hospitals and healthcare workers, but we are not tracking that information. But I know that the hospitals are, we've talked about this, I believe, in the past on some of these calls. Through our emergency support functions, through our Idaho Office of Emergency Management, we can support hospitals if they need support with security measures, for example, and that's where Idaho State Police would be activated to help support that. That has not occurred yet. So to me, that means that the hospitals around the state are able to manage those incidents that they're having locally. So I don't know if anybody else has anything to add, if they want to jump in, but I believe that's what we have right now, is not any complete information. It's all anecdotal at this particular point in time. And can you please repeat the second half of your question?
Yes, I was wondering if anyone has been in touch with anyone at ISU or any of the other community colleges that train future healthcare workers, and whether that's affecting recruitment.
Yeah, thank you. I'm sorry, I forgot the second half of your question. I think that's a great point. And again, we haven't heard that being the case. There's lots of incentives for nurses to move into the work field. There's a lot of monetary incentive, as Dr. Nemerson talked about. But Dr. Nemerson, I don't know if you had any experiences with that, but that's something we can certainly look into.
Not a lot. The one thing I do know is medical school applications are up nationally, and I do some work with the Idaho College of Osteopathic Medicine, and am aware that this entering class had the largest number of applicants in their history, and that's being experienced universally across the country. A lot of people believe that that's because the passion that a lot of our younger adults feel to serve is being they're starting to feel that that can be best served by entering healthcare. And so we're really, really glad to be seeing that, but I can't speak to nursing specifically.
All right, thank you. Our final question of the day comes from Ian Stevenson.
Thanks. This is sort of a follow-up to Kyle's question, and I apologize, I don't mean to make anyone repeat themselves, but regarding what you were saying before, Dr. Turner, if I understood you correctly, I believe you were saying that in terms of projections for future cases or hospitalizations, you were hesitant to trust a model at the moment, given the issues that there are with the caseload data in the dashboard. But I wondered if just because that 1900 November figure would be such a multifold increase over what we're seeing now, do you still expect to see sort of census numbers larger than what we're seeing at the moment, or what we saw at the end of September? Then I also wondered if perhaps Dr. Nemerson had thoughts on any modeling your hospital system has about what you're expecting seeing in the fall in terms of whether you're going to see more patients at once than you've seen so far or not.
Thanks, Ian. I'll have Dr. Turner, then Dr. Nemerson.
Thanks, Elke. Yeah, Ian, it's really hard when the data that's going into the model is not what it should be. So I hate to slam the door on you, but I'm going to hesitate to speculate about the projections at this point based on our case data that we're seeing. It does look like our hospitalization data has gone down a little bit in the last few days, but our admissions are still not going down. So I'll just turn it over to Dr. Nemerson to talk about what he's seeing.
So I'm waiting for an update on our predictive modeling for this week, but as of the end of last week, we were predicting a peak of inpatient hospitalizations in my own health system occurring sometime in the beginning of November, meaning that we expected to be in a plateau phase through that point in time. Beyond that, it's impossible to predict.
Okay, thanks everyone for your time today. We'll go ahead and wrap it up for today. We are planning another media briefing next week, same time on Tuesday, October 19th. Thank you for joining us today.